Morning, everybody. Thank the ISOT for giving this topic to discuss on this. So, organ transplant is a life-saving treatment, but often inaccessible due to cost and lack of limited infrastructure and logistics in India. So, let us see what was it in the past so that we can understand how we can move in the future. In 80s, when we started the program, maybe 80s and late early 90s, the focus was only on surgical, medical, and immunological. So if you have a trained surgeon, good hospital with a medical care, we did the transplant. But things changed. We had to. There was a Human Organ Act. Then came development in pathology, immunology. Immunosuppressants keeps changing. Donor screening, counseling became more important issues. Then came the disease organ transplant and the raw for it. Coordinators came in. Then the extended transplant program, and then comes these financial aspects, which already discussed now. Various workshop, conferences, and post-operative management. So the past, which was most on the technical aspect, changed over to various variables, which keeps on changing over a period of time. So where are we now? In US, 70 transplant is done every day, but still we are at 30 per day, though we need to be population-wise more than the developed country. So as per NOTO, we still have 30 per day, and deceased donor is 1,859, 51, including 3 cardiac deaths. So things numbers are very low compared to the demand, indicating a significant gap. Though we claim that we are the third in the world, but population-wise, it doesn't match in the ratio. So, what are the immediate challenges to overcome? One would be the cost, pre-op screening, waiting list, surgeries, post-op care, immunosuppressant, immunological monitoring. All these becomes a cost package, not the only surgery. Infrastructure deficiency, where you get a various types of licensing procedures, certain guidelines are put, may train manpower, equipment, specialized center, donor shortage. Awareness and education also become a problem because most of the transplant is judged by the public awareness and opinion. We have a certain opinion, the public has a different opinion. We need to bridge the gap. Regulatory and ethical framework keeps changing. Need for robust and standardized policy. And negative media perception is most important because if you say cancer, people are ready to pay. Whereas whatever you do in transplant, you are judged by thinking that something wrong you are doing. And then comes the digital era where the health literacy, digital literacy, and data gathering also is a issue which has to be overcome. So we have to cross all these challenges and see what should be the future challenge in transplant. At now this is, but in future when AI is going to come in, there will be technological advancement, robotics or xenotransplant research. Then comes policy and societal evolution. You can evolve in technology, but the society may be in the backward stage. So there should be a synchronizing among these two. And most important, come binding a sustainable ecosystem, expanding the donor pool, very important, though the various NGOs are talking about swap and various way to improve it, still centers are not able to get in. And then new funding model, which previously it was discussed. So let us see what we have been doing mistakes from the past. In 90s, the past model was why it failed because there was no law, donor exploitation was there was no data, anybody can do transplant anywhere and get away with it. So this is 1986, the first transplant, Dr. C.M. Tyagarajan, a private institute doing in a medical college, government general hospital now, after the CM was transplanted. So if you see the press release, the boiled drinking water given to the hospital was a news those days. So that was a situation where India was in 86, where even the drinking water, if you give it in a boiled state, was making news. But still, there was a model which was created where even the Ahmedabad group was trained first from the government sector, how a private and government can collaborate. And then IKDRC program evolved. So then in 96, again, issues were created where our own people started publishing in journals with the name of telling that India was a commercial hub. And if you see the name, the people who promoted it were also violently, were put in the journals reporting that Saudi Arabian people come to India for transplant. Then came the law. So in 2000s, after the Organ Transplant Act, certain evolutions came in, and there was an adaptation to regulation as well as technical and societal needs. So all three had to be synchronized, and we were able to do it until now. This is what is going. So there were hospitals in India where we use different kind of model. One such is MOU contract. Suppose I have a hospital which does a transplant, hospital B doesn't have, but they have a facility. These two people go into a contract. So this is a specific contract where they utilize the theater with certain understanding. So one group uses it, and this is a traditional MOU model where they have a patient, you do the transplant and come out. This is a limited time bound and prone to misuse. Certain areas they use even when they don't have a law there or not approved centers. Usefulness is that certain place they will have a good blood banking, NGOs could be supporting, but still there is a problem in the logistics. Then comes this hub and spokes model, which is now used in India widely, where there are chains of hospitals. So you have, say, a tertiary care center like Max or Apollo or Fortis. They would be the best center with all the facilities. They will have their own chain of hospitals, so they don't have to develop those chain of hospital in various other places. The team from the central hub will go to the spoke center, and their patient will be shifted among themselves. So usefulness is it rapidly creates a qualified team, upgrades the facility like Rela Hospital or Apollo, Fortis, Max or Kaveri. And even certain CGHs, railways have to agreement with one Apollo unit or a unit which applies for all their centers. So this hub and spokes model is what is expanding now in India, which is happening, but still the cost is high because there is no government involvement in it. Even though there are many government medical colleges, they don't use this model. So this is a model, and then comes the public-private partnership, which is for an agreement between private and a public and how to cut down the cost. So the collaboration is between the government entity and a private organization. And the characteristic is it leverages the strength of both sectors, aim to improve service delivery, infrastructure, and accessibility. So in short, it is a long-term contractual agreement where the public and private share the resource, risk, and responsibility for delivering asset or service to the public. So this is public-oriented, whereas the corporate is mainly business-oriented. So the National Health Mission in its review has given guidelines on PPP, but unfortunately it doesn't cover transplant because transplant has various aspects, as we said, immunological, pathological. So there are many things which you cannot put in PPP model. So they just have to given a broad guideline how agreement can be made. So again, Tamil Nadu was first in it. They had an MOU for liver, and they have been very successful with Rila Group, and NGO Group started this now in Manipur, where they had a PPP model. They could do the first cornea and kidney transplant. This is NOTO. NOTO guidelines also doesn't have a framework for PPP, how to have a PPP guideline. They just say organ allocation in certain small areas they give guidelines, but they don't give guidelines in a broader area because government sector is the one where you have the maximum number of patients. So this is for framework on how organ allocation model or how the NGOs can be incorporated. So the role of PPP is basically resource mobilization, infrastructure development. So the government nowadays builds various hospitals in various districts, but they don't have a specialized care. So by PPP model, they can allow public-private people to enter into these places and use the technological transfer, human resource development, efficiency of quality, optimization of the risk allocation, focus on long-term service, and ensuring public accountability and access. So this is the major criteria with which the government works, how much the general public is benefited. Now, how the cost is reduced? For example, in a private setup, if the tacrolimus cost is say 50 rupees, the government can buy it, even if it is IKDRC, they buy it for 10 rupees. So when you bulk purchase certain things, the cost comes down. And that is the reason why if a private entity gets some transplant in government, lifelong they will get a subsidized medicine. So economy of scale, centralized drug procurement reduces the cost. Services also government is subsidizing. And there is a standardized protocol. So whatever protocol is used in private can be used in public sector. Insurance and financing also. If one Apollo has got the approval of a finance, wherever they do, they will also be benefited. And there is a cross subsidization and technological integration. So, for example, you have a swap software. One hospital, if it is having, it can integrate with all other hospitals they have a MOU with. But there are problems in it. Whenever the government changes, if you have a central government, Calcutta may oppose it, Tamil Nadu won't take it. So you have a policy change, the government will say, no, we won't settle your bills. Contracts will be legally scrutinized, purposefully certain points will be picked up. And there is a financial risk because they may agree on payments, but the payments will be kept pending. So this happens sometimes even in dialysis models. Public perception is always that the government is not good, private is best. So we need to have a public trust, and then operational challenges. Certain places we have seen when we take the equipment to the government sector, we can't bring it back because there will be a problem telling that you leave it here, we will utilize it. And overall action is much more scrutinized than what it is in the private sectors. So whatever you do in government sector will be scrutinized not by them, but the people working in the government hospital who will also be opposing. So these are certain problems in PPP model which is not expanding across the state. But still there are areas to collaborate, like organ procurement and allocation, we need to strengthen it. Transplant centers has to be promoted more in second and third tier cities. Post-transplant care, most of the time we do talk about cadaver, but no centers gives us the long-term data. What is the 5-year survival of transplant done in the government hospital, though they get the priority. Research and development needs collaboration. And most important is public awareness campaign. So now, having gone in this, what we see is there are newer areas coming in, mainly for integration of AI technology or use of drones for transport or swap softwares. Now, when these new things come in, where are we going to integrate it first? Can PPP model, which has been agreed upon 5 years back, cannot integrate it? So there is a lacuna in these things. So their NGOs are getting into this picture, but still we are not able to move forward. So we are proposing what we call as integrated PPP model. So what is this integrated PPP model is? Traditionally, traditional model focus on the specific task, but integrated involves broader, more deeply interwoven partnership across the entire donation and transplant pathway. For example, I appoint as a best center. They in turn can agree with many other people, so I don't need to interfere with them. So it becomes an integration. So there is a flexibility. So this model will be suitable for India because we can also get in NGOs, we can get in the foreign ideas, whatever happens anywhere can immediately integrated into the existing model. So these are the various differences between traditional and integrated model. And now let us see the data which we are getting in. So if you see the Gujarat, they have been doing well because it's well funded, well organized. We have a lot of manpower in this area. Tamil Nadu also is doing well. and major success achieved after 2016 basically because of certain central supported dialysis is the West Bengal model. But unfortunately, if you see the West Bengal data, there is PPP model in free dialysis. There is no PPP model in transplantation. So to conclude, if we have to go on a sustainable path, PPPs are crucial for creating a sustainable and affordable transplant ecosystem. A strategic collaboration can transform the access. And the future is a greater synergy between technology, policy, and collaborative model to enhance healthcare delivery and accessibility. Jai Shri Ram.